Sirshendu from Siliguri. I invite Dr. Sirshendu from Siliguri. He is a senior consultant and physician in diabetologist. And I think he is going to please credit. There are a lot of the things to describe. Because of the lack of time, and I think we will avoid that. And straight away, I request Dr. Sirshendu to start this topic.
Yeah, very warm good evening to all. Happy to be in Baroda, the cultural capital of Gujarat. And at the outset, I would like to thank the organizers, especially Dr. Vyang Shah, Dr. A.K. Singh, and Dr. Vijay Patni, to give me this opportunity to present pulmonary arterial hypertension. Nothing to declare, sharing my thoughts. What is pulmonary arterial hypertension? Pulmonary hypertension is pressure of the pulmonary artery more than normal. The usual pulmonary arterial pressure is 14 plus minus 3.3 millimeters of mercury, and the upper limit of normal is 20 millimeters, 20.6 millimeters of mercury. And if the mean pulmonary artery pressure is more than 25 millimeters of mercury, it is deemed to be pulmonary hypertension. The golden rule to diagnose pulmonary hypertension, we all know from our medical school days, is right heart catheterization. Other definitions include left ventricular end diastolic pressure more than 15 millimeters of mercury, or even the post-capillary pressure more than 15 millimeters of mercury. Those also come under the domain of pulmonary hypertension. The pulmonary hypertension is characterized by progressive remodeling of the distal pulmonary arteries, and this remodeling leads to elevated pulmonary vascular resistance, ultimately leading to right ventricular failure when usually the symptoms develop. The early phases are usually asymptomatic, and the diagnosis is perhaps delayed, maybe by up to 2 years in most of the people. And that's perhaps the reason that the means of this survival time of pulmonary hypertensive patients is around 5 to 6 years. This is the classification of pulmonary hypertension. This is the WHO classification. And as per this, the group 1 includes the idiopathic pulmonary arterial hypertension, heritable pulmonary arterial hypertension, and toxin-induced pulmonary arterial hypertension. Besides pulmonary hypertension arising from congenital heart disease or schistosomiasis. In India, or in fact in Southeast Asia, schistosomiasis is a very important cause of pulmonary arterial hypertension. Then comes the second group, where it's due to heart failure arising from reduced left ventricular ejection fraction, or even preserved left ventricular ejection fraction, valvular heart disease, or congenital or acquired cardiovascular conditions leading to post-capillary pulmonary hypertension. Group 3 includes the lung diseases, the obstructive lung disease, the restrictive lung disease, a combination of the two, hypoxia without lung disease, and development of lung disorders. Herein, I'd like to add, please remember at the outset, the topic may seem to you that it's an atypical topic, but actually pulmonary hypertension is a very important topic for the next 3 to 4 years for India or for the world, because we had all suffered from COVID, and the behind the scene pathology of the main pathology of COVID is lung fibrosis, and this lung fibrosis leads to pulmonary arterial hypertension. So in the years to come, be confident to manage pulmonary arterial hypertension and be apprehensive of its high morbidity and mortality. Coming to group 4, chronic thromboembolic pulmonary hypertension, that's due to pulmonary artery obstruction. The pulmonary obstruction may also be due to sarcoma, angiosarcoma, other malignant tumors, renal carcinoma, uterine carcinoma, germ cell tumors, even non-malignant tumors, that's a leiomyoma, or the connective tissue disorders. Connective tissue disorders, the most important being the scleroderma, or the progressive systemic sclerosis. Hydatidosis also may play a role. Last comes the group 5, where the etiology is unclear, includes the hematologic disorders, chronic hemolytic anemia, the storage disorders, the Gaucher's disease, glycogen storage disease, neurofibromatosis, sarcoidosis, or the complex congenital heart lesions. Now coming to the clinical features, we all know, but we are more likely to miss it. Please remember, it's very important. Breathlessness, that's when it's diagnosed, but perhaps it should be diagnosed when there are episodes of syncope, edema or swelling, chest pain, weakness, fatigue. My patient usually in the initial stages presents only with fatigue. All these should raise the clinical suspicion of pulmonary artery hypertension. Now coming to the pathogenic pathways and drug targets in pulmonary artery hypertension. We all know, you can see the picture of the normal pulmonary artery, and when this is affected, there is vasoconstriction, intimal hypertrophy, smooth muscle proliferation, ultimately there may be in situ thrombosis. The next picture on the lower outer quadrant shows, there is thickened musculature and leading to the pulmonary artery hypertension. The mean pulmonary artery pressure rises, there is increase in pulmonary vascular resistance, decreased cardiac output, very important. Also right ventricular remodeling and ultimately right ventricular failure, which is the end point. And what do the drugs act? You can see well delineated from the picture, there are 3 sites of action. One is the endothelin pathway. Endothelin 1, we all know that leads to vasoconstriction. If you can block it with the endothelin receptor antagonist, you can retard the progression of pulmonary artery hypertension. Similarly, there is a nitric oxide pathway. You all know nitric oxide is a very good vasodilator. And this nitric oxide accumulation may be increased with the soluble guanylate cyclase stimulator, or the degradation of nitric oxide may be reduced by the PDE5, that is the phosphodiesterase 5 inhibitors, and all these would lead to increased cyclic GMP, and the cyclic GMP accumulation would lead to vasodilatation, thus retarding the progression of pulmonary artery hypertension. And last but not least, there's the prostacyclin pathway. That's the drugs which you used to use a few years back. Now we are more shifting to the endothelin receptor antagonist. These prostacyclin derivatives increase the cyclic AMP levels, causing the vasodilatation. Risk factors, the PRT gene mutation, that's a bone morphologic protein receptor 2 mutation that you may detect through genotyping. There is another atypical one for diagnosis is the pulmonary embolism, for which you need the VQ scan, but for the other conditions, that's the portal hypertension, HIV infection, sickle cell disease, or systemic infections. All these lead to right ventricular effects, and these are well detected by echocardiography. You may do the bubble test. In X-ray, you'll get some findings. That's the peripheral pruning of the vessels. Also in ECG, there are findings, the right bundle block, right ventricular dominance, right ventricular hypertrophy, so on, and right bundle block, so on and so forth. I'm not going to the details. Treatment goals. As you all know, for any cardiovascular or respiratory cases, the aim of treatment is to reduce symptoms. Please try to improve the patient's symptoms, enhance functional capacity, that is lowering the mean pulmonary arterial pressure, reverse or at least prevent. It's not possible to reverse actually, prevent progression of the disease and improve survival. General measures, go for low-graded exercises such as walking, but don't go for prolonged walks as much as he can tolerate. Avoid exposure to high altitudes, sodium-restricted diets to less than 2.4 grams per day. Immunization against influenza, pneumococcal pneumonia, very important. Very often we fail to address this issue in COPD or bronchial asthma patients. Anticoagulation and diuretics. Coming to the treatment algorithm, after this anticoagulation, with or without diuretics, with or without oxygen or digoxin, assess for acute vasoreactivity. What is acute vasoreactivity? It's nothing but reduction of the pulmonary artery pressure to less than 40 millimeters of mercury after reduction of 10 millimeters of mercury arterial pressure. The pulmonary artery pressure should go down by more than 10. And if it's so, then it will probably respond to calcium channel blockers. And if the calcium channel blockers work well, you can continue the calcium channel blockers. However, in this acute vasoreactivity testing, if the test is negative and if the patient is of low risk, you may start with older drugs, that is ERA-PDE5 oral or treprostinil IV, iloprost, or treprostinil. Treprostinil may be given in 3 forms, IV, subcut, or even oral. If it progresses, you go for the IV medications, and ultimately, if these do not work, you ultimately have to go for atrial septostomy or a lung transplant. Invasive therapies, many patients experience progressive declines. Not many, actually all patients go for progressive decline in function, largely related to worsening of the right heart failure. And in these patients who worsen very fast, you may go for atrial septostomy. It is indicated when there is severe pulmonary hypertension and intractable right heart failure, despite maximal medical therapy, or you can use it as a bridge therapy prior to transplant, that is palliation with restoration and maintenance of clinical stability until lung transplantation can be performed. The end management would be the heart and lung transplant, or sometimes you may need the surgical thromboendarterectomy. Other surgical approaches may be the Bivacor, that's a biventricular assist device, which has been used for some patients, but still it's under investigation. Now coming to the newer molecules, my actual topic. This is the latest molecule, the riociguat. It is a soluble guanylate cyclase stimulator, increases intracellular cyclic guanosine monophosphate by directly activating the soluble guanylate cyclase, and this leads to pulmonary vasodilation and platelet inhibition. It was initially approved for cardiothoracic pulmonary, thromboembolic pulmonary hypertension based on the CHEST-1 trial, but later it was used for this pulmonary hypertension and it reduced, and please remember it has shown very good effects. However, smoking should be prohibited as the bioavailability of riociguat reduces by 50 to 60%. Or you may go for dose adjustment if more smoking is continued, but please ask your patient repeatedly at each clinic visit to quit smoking. Riociguat is generally contraindicated in patients on PDE5 inhibitors due to increased risk of hypotension. In patients with suboptimal response to PDE5 inhibitors, you may ask this molecule, and the RESPIRE trial showed that increases the 6-minute walk distance by 31 meters, a decrease in NT-proBNP and other manifestations of right ventricular functions. However, the drawback is it causes serious adverse events in 52% of the patients, and 16% patients are afflicted very much, though some studies have shown the actual these events are only 3% directly related to the molecule. In the recently concluded REPLACE trial, these findings were confirmed, and the delay in clinical worsening and disease progression is perhaps retarded if you switch to riociguat from PDE5 inhibitors. Now coming to selexipag, again a good molecule. It's a non-prostanoid oral drug that is highly selective to prostacyclin receptors. It promotes pulmonary vasodilation and inhibits platelet aggregation. It has been approved by FDA for functional class 2 and 3 patients. Dose is start low and go slow. Start with 200 micrograms twice daily. You may increase it up to 1600 micrograms twice daily. It was studied in the double-blind, placebo-controlled, randomized controlled trials, 3 of them, and the last one is the Griffon trial, which demonstrated a reduced risk of hospitalization and death compared with a placebo. The trial concluded that including selexipag monotherapy or as an add-on therapy to endothelin receptor antagonists or PDE5 inhibitors compared with placebo demonstrated a clinical reduction in worsening. This is very important. Initially, the drugs that we had only improved the exercise tolerance, but selexipag is one drug which retards this clinical worsening. Patients may need to be transitioned from one drug to another based on tolerability and side effects. The Transit-1 study found that slow-down titration of inhaled treprostinil and up-titration of selexipag was well tolerated and safe in pulmonary hypertension patients with functional classification 2 or 3. Again, a new drug, the ralinepag, is a selective non-prostanoid prostacyclin receptor agonist, an immediate-release oral drug that is currently being studied. And the randomized controlled trial have shown that there is reduction in the pulmonary vascular resistance by 163.9 dyne, increasing the 6-minute walk distance by 36 meters in patients receiving this as monotherapy or as combination therapy. Currently, a number of trials are going on. That's the advanced capacity trials, the advanced outcome trial, and the advanced endurance trial to assess the safety, efficacy, and the survival benefit of this molecule. Coming to the best one, the sotatercept, it's a selective ligand trap for transforming growth factor beta. And the recently published PULSAR trial demonstrated that improved, again, the 6-minute walk distance by 29 meters and decreased the NT-proBNP in sotatercept group compared to the placebo. Thrombocytopenia and increased hemoglobin were the chief adverse events. There is a phase 2 trial, a SPECTRE trial, also investigating the efficacy of sotatercept in pulmonary artery hypertension, with the primary outcome being the change in peak oxygen uptake from baseline. And it's good till now. Being the first drug in its class, the FDA has assigned it as a breakthrough therapy. A phase 3 stellar trial. Here it's written the results are expected. Actually, the results have come out and it's being published in 2023 in the JIMA and also available on PubMed. You can go through it. Now coming to the other drugs, my last slide. Some other drugs are also being evaluated, but they are not into clinical trials as yet, still in the labs. The bardoxolone-methyl, which acts on the anti-inflammatory pathway. Imatinib, which is a tyrosine kinase inhibitor. The vasoactive intestinal polypeptide. Endothelial nitric oxide synthase couplers. The sapropterin dihydrochloride. Fasudil, which is again a Rho kinase inhibitor. Terguride, a serotonin receptor antagonist, or even apelin. All these are being studied in the management of pulmonary hypertension. Finally, what we are looking at now it has been found using a combination therapy is perhaps better than using each of these molecules in isolation, and that improves not only the hemodynamic status, but also the functional status. The latest trial is the AMBITION trial, which found that a combination therapy of ambrisentan and the tadalafil improves not only the symptoms, but also the clinical parameters, the pathological parameters. An upfront triple combination therapy for intermediate risk and high-risk patients seems logical and leads longitudinal study to assess actual benefits. So thank you all for your very patient listening.
Thank you, Dr. Pal. You have described very nicely all the clinical classification, pathophysiological pathway, treatment algorithm, and newer drug also. So any just one or two questions from audience?
Yeah, obviously. You go for it only when the right atrial pressure is above the left atrial pressure. In fact, that's the same for congenital heart disease. When the right shunt is more than the left, then only you go for the atrial septostomy as a bridge therapy, yes. No, atrial septostomy is not that you totally clear the chamber out. It's not that. It's done partially one, and next is a bridge therapy. The total blood is not shifted. Yeah. Going for transplant, yeah. No, it's, why do you say it's not recommended? It's still in the guidelines. Sildenafil, tadalafil is still in the guidelines. It's a PD5 receptor antagonist. But what it does, it improves the exercise capacity, but the clinical parameters, that the deterioration of the disease is not improved by sildenafil or tadalafil. Understood? That is improved only by ambrisentan or brosentan when you use it with treponistil. Okay, but it's not that the symptoms are not improved. If you go through the Harrison also, you'll find still it's in the guidelines, and it improves exercise capacity, but does not improve the decline in the pulmonary function. Okay? No, in COPD patients, you can use it as an additional therapy only when the pulmonary artery pressure is increased. Unless and until the pulmonary artery pressure is more than 25, and in fact, in this case, using that molecule, ideally you should go for the left ventricular end diastolic function also, one, and the post-capillary pressure. Those also should be more than 15. Then you can start that molecule, and then only it produces benefits. Any other questions, please?
Thank you, doctor. Because of lack lack of time.